Welcome to The Seasoned Sonographer, the podcast where experience meets education in the world of OBGYN ultrasound. My name is Lynn Flam, and I'll be your host. I'm a registered diagnostic medical sonographer with over 32 years of experience, most of that time in OBGYN ultrasound. Through this podcast, I'm here to share insights, tips, and case studies to help you sharpen your skills and optimize your scans. Whether you're just starting out or you're a seasoned pro, this is the place to grow your knowledge and confidence. Let's dive into today's episode. Hi, everyone, and welcome back to The Seasoned Sonographer. I'm your host, Lynn Flam, registered diagnostic medical sonographer. I'm so glad you're here with me today. In this episode, we're diving into the third trimester ultrasound. We'll cover what we measure and how we evaluate fetal position and amniotic fluid, and when it might be appropriate to add a biophysical profile or BPP. Then I'll be joined by certified nurse midwife Jessica Reichert, who will share her perspective on how these late pregnancy ultrasounds influence clinical care and even the timing of delivery. Let's start with the basics. A third trimester ultrasound isn't part of standard of care for every pregnancy. It's usually ordered when there's a specific reason to check on baby's growth, position, fluid, or follow up on an earlier concern like placenta location or a known anomaly. It's typically done on the growth when there's a high BMI. If they have pre-existing comorbidities like hypertension, gestational diabetes, or even pre-existing diabetes mellitus 1 or 2. It's a scan that can give important insight as we get closer to delivery, and it sometimes raises red flags that lead to changes in surveillance or even changes in the delivery plan. Next up is fetal biometry. These are standard measurements we take to estimate fetal size and growth. We use the head circumference, the BPD, the AC, and the femur length. And we all know that the BPD is measured outer to inner at the level of the thalamus cavum, septum pellucidum, and midline falx. The head circumference is measured outer to outer using the elliptical on the outside of the skull. The abdomen circumference is at the level of the stomach and the umbilical vein at the portal sinus. The spine is in cross-section, seeing those three ossification centers. And when we measure the outside, including that subcutaneous soft tissue. The femur length is measured horizontally, perpendicular to the ultrasound beam so that you get good crisp edges. Make sure you have a nice posterior shadow, excluding those distal epiphysis, measuring the main shaft of that femur length. So we use these values to calculate the estimated fetal weight, and that gives us a percentile based on the gestational age. So if the baby is less than 10th percentile, we consider that fetal growth restricted, or say the baby has FGR. If the baby's above the 90th percentile or 95th percentile, we start to consider macrosomia. And both of these findings may trigger additional monitoring. They'll consider the timing of delivery or even a consultation with maternal fetal medicine. Let's talk about fetal position. This becomes extremely important after 36 weeks when we want to know if the baby is head down or cephalic or vertex. Those are terms used interchangeably. Or if the baby is breech. And there are different types of breech. Frank breech, complete breech, footling breech. So ultrasound is the most reliable way to determine the fetal lie and presentation. So especially in patients with a high BMI or an anterior placenta, it's hard for them to tell from the outside just by feeling. So this ultrasound helps guide whether an external version might be attempted or whether a cesarean section is more likely. So be sure to put in your report what type of breech it is. This would help the provider make these decisions. The next is the fluid assessment. We use two main techniques to evaluate the amniotic fluid. The amniotic fluid index is the sum of the largest pocket of fluid in each of the four quadrants. And the single deepest pocket, SDP, also known as the MVP or maximum vertical pocket, is the depth in centimeters of the largest vertical pocket of fluid without fetal parts or umbilical cord. The MVP is a method of measuring the depth in the largest pocket. It's considered a reliable, often preferred method, especially in cases of multiple gestations or twins, even triplets, because it reduces the risk of overdiagnosing oligohydramnios. So a normal AFI is between 5 and 24 centimeters. Below 5 is oligohydramnios. Above 24 is considered polyhydramnios. And with the MVP, the values are between 2 and 8. So less than 2 centimeters suggests oligohydramnios, and above 8 centimeters indicates polyhydramnios. Too little fluid may suggest placental insufficiency or ruptured membranes, while too much fluid can be associated with diabetes or other fetal anomalies. When fluid is borderline or hard to evaluate, you can ask the patient to reposition, kind of turn on their side and then roll back on their back, hydrate, or come back in a few hours, but that is very challenging when you're working with an already overbooked or double booked schedule. So that's not likely. Just do the best you can to get as accurate as you can at the time. As we all know, ultrasound is a real-time exam, and it's very sonographer dependent. By the third trimester, these exams can be more technically difficult due to a variety of factors. Maternal body habitus and BMI is huge. This can limit the sound penetration, and especially if you have to work under a very large pannus at times to get the best image. Oligohydramnios or low fluid makes it hard to define structures. Fetal positions such as face down or spine down or breech, or a lot of times by the late third trimester, that fetal head is so deep in the maternal pelvis, you really have to get low and angle and make sure you're doing your best to get those fetal head structures and landmarks that we look for. Advanced gestational age is where the baby is just simply too large to get ideal angles or full measurements in one image. So what do we do when we can't get a clear image, when we can't be confident in the measurements that we've taken? And sometimes that can be frustrating, right? If you're unable to get those accurate images and get your right landmarks or measurements due to maternal habitus, fetal lie, or other limitations, clearly state that in your preliminary report. It gives the provider context and supports informed clinical decisions. Some ways that you can improve imaging may include repositioning, waiting. The important thing is to acknowledge and document any limitations. That transparency protects both the patient and the provider. There are so many times when I say unable to obtain an accurate fetal head measurement due to maternal habitus and fetal position and late gestation. Landmarks are seen but not confident in measurements or something like that. Just document all that in your preliminary report so that they have an idea how confident you are in those measurements. The same thing can happen when you're doing an abdomen circumference. If there's a knee up there or both knees up there, that AC can be distorted and maybe not round. And just say that. Appears to be measured at the right level, but it's not round due to fetal position. So when do we add a biophysical profile to all these measurements? We can add a biophysical profile to see how baby's doing in real time when there's decreased fetal movement. The BPP looks for fetal movement, fetal tone, fetal breathing movements, and amniotic fluid. Each one of those categories gets a score of 0 or 2 for a total of 8. Sometimes a non-stress test is added. If you get a 6 out of 8, they'll add an NST to obtain those extra 2 points, and then that can give a total of 8, and then, a possible total of 10 is available. We typically add a BPP when there's decreased fetal movement, or if the patient has hypertension, diabetes, or any other complications or comorbidities. If the baby is small, has fetal growth restriction, or the fluid is low, they'll add a BPP. With growth restriction, they often add umbilical cord Dopplers, checking that umbilical artery flow in the umbilical cord. It's a helpful tool to do the BPP, especially in high-risk pregnancies, to decide whether the provider can continue watchful waiting or if delivery should be considered. So now that we set the stage and talked about what we look for during the 3rd trimester ultrasound, I'm excited to bring in today's guest. Jessica Reichert is a certified nurse midwife who works closely with both OB patients and sonographers in their daily practice. She has seen firsthand how a late pregnancy scan can change the plan, and today she's sharing that perspective. Today, I would like to welcome Jessica Reichert, certified nurse midwife, to our episode about 3rd trimester ultrasounds, their role in clinical decision-making and timing of delivery. Welcome, Jessica.
Whoop, whoop. Thanks for having me.
All right, so can you tell us a little bit about your journey into OBGYN as a certified nurse midwife?
My journey is not what most people's are. When I was in nursing school, I actually wanted nothing to do with moms or babies. I was like, that's not supposed to come out of there. That's, yeah. First birth I saw, I was like, that's a no for me. And then somewhere along the way, I got into NICU, and I was like, oh, I can do the baby stuff, but not the mom stuff. And then somewhere else along the way, I was like, okay, this is incredible. Let's do this.
Awesome. So when you hear 3rd trimester ultrasound, what's the first thing that comes into mind in terms of clinical importance?
I typically think of like the fetal growth restrictions that we tend to catch, because that does affect their clinical journey so much in terms of the surveillance we're doing, induction dates, all those kinds of things. I feel like we catch a lot of fetal growth restriction with that.
Right. So what are some of the main reasons then that you would order a 3rd trimester ultrasound? I know for the suspected fetal growth restriction, if you measure their fundal height and it's small, you would get a 3rd trimester ultrasound for that. What are some of the other reasons that you would?
So anytime we're having a size dates discrepancy with fundal heights, whether baby's too big or too small, it's pretty accurate, but it's not a perfect thing. So ultrasound really helps with those size discrepancies. But anytime we have any risk factors that can impact growth, like chronic hypertension, advanced maternal age, diabetes, twins, anything like that, those 3rd trimester growth scans really help us to keep an eye on those kinds of things.
So how has 3rd trimester ultrasound and scanning changed over the last few years? Do you feel like? I feel like we're doing more 3rd trimester ultrasounds and checking growth more often because there's more comorbidities happening.
Yep, I agree. I feel like it's become much more common and much more routine for prenatal care because everybody is so much more sick during their pregnancies. And like you said, so many more comorbidities. However, I think that what I would be interested to see if we had research on this, if we're doing more interventions since incorporating these more. Because I mean, there's a discrepancy ranging from like 15 to 20% above or underweight. And then sometimes that can affect, the counseling that we're giving to patients and induction dates. So I'd be really curious to see if the more we're doing these, if we're doing more interventions and kind of how that's affecting outcomes.
Right. And something that's really changed in my career and over my 33 years, for crying out loud, is obesity became a risk factor. Mm-hmm. And that's huge because we're in an epidemic of obesity in our country. And it seems like that makes a lot of people at higher risk for then hypertension, diabetes, gestational diabetes, and those kinds of things.
Yep.
When you identify something like fetal growth restriction, how quickly does that change the management plan?
It changes things immediately. When we have those fetal growth restriction babies, that shows us that there is something between the blood flow between the placenta and the baby, that the baby's likely not getting enough blood flow affecting their growth. So we quickly get a referral to maternal fetal medicine, the OB specialists, who help us continue to kind of monitor the pregnancy, determine the safest time for delivery. We increase the antenatal surveillance, which is, the NSTs and the BPPs, where we're getting the ultrasound to check fluid movements, blood flow through the Dopplers, through the umbilical cord, all of those things. And so we have
Right,
to act on it
right.
pretty quickly.
And when those unexpected findings show up on that third trimester scan, how do you approach counseling the patients about it? Because, I mean, they came in to check the growth of their baby and the fluid and maybe get some 4D pictures, and then the rubber hits the road.
I feel like usually what we're discussing isn't the first time it's been brought up, especially if it's in regards to concerns for growth.
Right.
Because we do, those fundal heights, and we usually have a good eye on, well, we're measuring a little bit behind or a little ahead. So usually we have had talks about it, a handful of times before the official ultrasound. If it's something that hasn't been discussed, I mean, we're not here to give any like fear mongering to cause any issues with that with patients, but we also aren't here to lie to them. I think just having a
Right.
very direct conversation of, these are the findings, these are the risks associated with the findings, these are recommendations, and then kind of coming together to use some shared decision making for their plan
Right.
here.
And then can you give an example of where ultrasound findings may have prevented a bad outcome? I know you see this all the time, but can you think of one that stands out where, it really made a difference to have that third trimester ultrasound, and then it, really prevented a bad outcome?
Yeah, I mean, I can think of one patient specifically who had that third trimester growth, was documented fetal growth restriction. I think she came over to the hospital because her NST was non-reactive or something.
Mhm.
And then when she got there, baby was having some dips in the heart rate, but it wasn't overly concerning because they were just very occasional. It's nothing that we would have
Mhm.
immediately interacted on to cause, urgent delivery. But we ended up getting a BPP because, we knew she had the fetal growth restriction. So we got
Right.
the Dopplers as well. And she ended up having, I think it was absent flow. So she ended up being delivered that same day. And I mean, had we not caught that, who knows? Who
Right.
knows what
What
would have
would have
happened to that
happened?
baby? Yeah.
Increased risk for fetal mortality. I
Yep.
mean, what would, well, you kind of touched on, what would automatically make you consider early delivery? I guess when you get a BPP that's abnormal, and then maybe an NST, or how does that work? When would you
So
do
when we
that?
have those abnormal NSTs or BPPs, it usually just leads us for more monitoring or further testing. Because I mean, as you know, a baby can have points off for breathing, and then we redo it an hour later, and they're perky and happy and doing all the things that we need to do. But anytime we have those reverse or absent flow Dopplers, that shows us that the blood flow through the umbilical cord to baby is either not happening or is essentially backflowing, which
Hmm.
is very, very dangerous. Um,
That
uh,
would prompt immediate
yes.
delivery then. Yeah.
Yep.
Okay.
Yep. Otherwise, fetal growth restriction, oligohydramnios. Anytime we have twins, that definitely increases the risk of preterm delivery if we have, twin to twin transfusion or anything like that.
Right. Right. So how closely do you follow those ACOG recommendations on timing of delivery? And or are there cases like where your clinical judgment just takes the lead and you're like, I'm not gonna deliver them just yet. I'm gonna do a little more monitoring or something.
Yeah, I feel like we almost always follow ACOG's guidelines.
Yeah.
Sometimes, I mean, laying eyes on the patient and actually seeing the strip and the ultrasound can definitely impact what we're recommending with the patient. Anytime we have a preterm patient or a patient who's got some of these higher risk factors, we also like to collaborate with maternal fetal medicine to kind of run it past them, say, I know these are ACOG's guidelines, but this is what we're seeing based on, the whole clinical picture. And then we kind of can come up with them to find a plan of, okay, is it safe to, expectantly manage and be doing closer antenatal surveillance, or is this something that we actually need to move up on the delivery timing based on what we're seeing? So it's really nice to have those people that we can run those things by.
So, what are some examples of the third trimester ultrasound findings that might trigger additional testing like the biophysical profile or umbilical artery Dopplers or MCA Doppler studies?
Fetal growth restriction always tends to be the primary one that we're doing those with. However, anytime they have other risk factors like chronic hypertension, diabetes, especially if it's requiring any medication management, all of those can have effects on the placenta, which in turn, can affect blood flow to baby and growth. So those are usually the biggest things I feel like that we're getting those additional
Right.
BPPs and ultrasounds
And
for.
then kind of going back to the delivery timing, how do you balance that emotional side, like, and the anxiety of the patient when you're deciding to do the early delivery based on, findings?
I mean, again, a lot of it comes back to it's likely not the first time we've had that conversation before.
Right.
I always like to tell patients, especially when we're in the hospital, that our goal is never to blindside them unless, the baby's blindsiding us, which babies do what they want. So that does happen. But I feel like we are very focused on the shared decision making and keeping patients in the loop and educating them on what we're seeing. So I think the biggest thing is just, again, being direct about what we're seeing, the risks that can come with either the comorbidity or whatever diagnosis we're making, and then coming together to make a plan with them after, if it's something really high risk, speaking with our backup docs, our collaborating physicians, and then allowing them to have a say in the plan, because it's not about us, it's about them and their pregnancy. So I think giving them the power of how they want to move forward and giving them the education to make those decisions can really be impactful.
And then with those decisions, you said there was one fetal growth restricted patient that stood out to you. What lessons did that case teach you about ultrasound, about communication, about patient care? I mean, because every time, there is something that doesn't go quite as we expect, we do learn something from those situations. And, what were some of your maybe things that you learned?
I think just the fact of how important those Doppler measurements are, because I think up until then I had never had any that were absent or reversed.
Okay.
And it was interesting because if I was looking just at the NST, again, the baby had some occasional dips here and there, nothing overly concerning where we would, again, expedite delivery, because most likely all babies will have dips here and there because we don't have them continuously monitored, then we just likely don't see it. But looking at the strip, I would not have been like, hey, this baby is not getting adequate blood flow, we need to have a baby today. And
Right.
then getting those results, I was like, okay, that's
Yeah.
kind of not misleading, but it was just really eye-opening to me.
Made things clear that what you needed to do.
Yeah, why we have both the Dopplers and BPPs in addition to the NSTs.
Okay, so looking forward, are there any new technologies or protocols you're particularly excited about in the world of third trimester monitoring? I mean, I'm thinking of things like the obvious AI and, point of care ultrasound that providers are now doing bedside, even, in clinic. Are there any of those things that you're excited about?
I haven't really heard of any new protocols or anything. I think the possibilities with AI and the ultrasounds are probably endless. I think it'd be interesting to see, if you could input some ultrasound photos into AI and kind of see what they could come up with of what do you think my newborn's going to look like, or just, I don't know. I think it's,
or confirm measurements, when the tech is doing it, if they're inexperienced, maybe just that validation from AI that yes, this is a good image of the fetal abdomen, this is a great place to measure or whatever.
Yeah, or I mean, even picking up on something that the human eye might not have caught on that ultrasound that AI might be able to pick up.
Right, any abnormalities, or AI might suspect a fetal abnormality that could be followed up on.
Yeah, absolutely.
Well, what advice would you give to newer clinicians or sonographers who are just starting out to understand the impact of the third trimester ultrasound? What advice would you give to a new midwife maybe that's starting?
Yeah, our ultrasounds definitely directly impact our management and our plan of care. Being the new midwife, and we didn't have a lot of training on interpreting ultrasounds, just being able to go to ultrasonographers who've done this for years and years and years and saying, okay, talk to me like I'm 5. what are we seeing here? Because we're not trained to interpret the image itself, more so trained to say, okay, this is what has been found. How do we create our diagnosis off of that? So I think being able to talk to the ultrasonographers and kind of go through their findings helps me understand those diagnoses a little bit more sometimes too, seeing what they're seeing and how that's impacting our diagnosis.
Right. Okay. So any final thoughts for sonographers or providers or anything else you want to say?
I don't think so. I think I kind of like that the third trimester scans are becoming more routine because I think it's always just fun to get a peek at the babies when they start to chunk up in the third trimester. They start to get their little
and
chunky
those 4D
cheeks
pictures.
and the 4D.
And then too, what a great way to check in after that 20-week anatomy scan, because it's so much time till term, and you don't really know how baby's doing. I mean, you can feel from the outside and all that kind of stuff, but you really don't know unless you look. So
and stranger things have happened, so it's always it's just nice to get a peek on the baby.
Okay. Well, thanks for coming on. I really appreciate your time. It's always fun, and I sure do enjoy listening to all the great advice you have to give.
Well, thanks. I appreciate you.
Thank you so much for joining me for this episode of The Seasoned Sonographer. If you're interested in improving your OBGYN ultrasound skills and learning more about the field, make sure to subscribe to The Seasoned Sonographer on Apple Podcasts, Spotify, and YouTube. You don't want to miss any of the upcoming episodes. You can also connect with me on Facebook and Instagram at Sonotechniques Academy. Explore more educational resources on the Sonotechniques Academy app, or reach out via email, lynn@sonotechniquesacademy.com. I'd love to hear from you. If you have questions or topics you'd like for me to cover, feel free to reach out. This podcast is for you, and I want to make sure I'm covering the topics that matter most to you and to the ultrasound community. Until next time, keep striving for excellence in your scans, and I'll see you in the next episode of The Seasoned Sonographer. The information provided in this podcast and any accompanying materials is for educational and informational purposes only. It is not intended as a substitute for professional medical advice.